Hi everyone, good evening. Welcome to this evening's Mind the Bleed webinar. Today we're going to be going over upper GI bleed, and this webinar is kindly put together by Dr. Lizzie Evans, who's an SE2 anesthetics. Please put any questions that you have for us in the chat as we go along, and also just to note, at the end we're going to just send a feedback link through as well. We would be very grateful if you could fill that out. But without further ado, let me hand over to Lizzie to take it away.
Great, thank you. So hi everyone, my name's Lizzie, and as you said, I am in my ST2 year of anaesthetics ACCS in South West London, and today we'll be covering upper GI bleed as our topic. Let's see if this works. Oh, hang on, it doesn't seem. Oh, here we go. This is our sponsors of the MDU, which I'm sure they'll tell you about a bit later. So upper GI bleed. So today we'll have a quick introduction, and then I've structured the teaching in a case-based format. So all of it will be, the content will all be in case within the case itself. It's a case I've made up. It's not based on true events, but hopefully it makes it a bit more engaging and a bit more interesting as we go. It's a little bit difficult to make this interactive, but we will make it as interactive as possible by trying to get you to engage on the Facebook Live comments. So it'll be a bit trial and error, but let's see how it goes. So upper GI bleed, so the definition of that is a hemorrhage anywhere between the mouth and the duodenum. It's a common medical presentation whether you're at GP, working in A&E, or on the surgical and medical wards. The inpatient hospital mortality is about 10% according to NICE, so it has a high mortality rate, and it's an important pathology to be able to identify and have some confidence in treating. Equally, I think it's an important topic to go through because your first proper upper GI bleed is pretty dramatic, and it can make a lot of people panic. Teaching sessions like this aren't going to remove the drama behind it, but hopefully it gives you a bit more confidence in how to approach these patients when you're working as an F1 and working your way through your medical career. So let's go to our page presentation. I'm just going to move this out of the way so I can see. So the scenario is that you are the F1 on call. You're covering the medical wards. You're pottering around doing some jobs, having a cup of tea, when suddenly your bleep goes off as a peri-arrest for the ward opposite you. You very diligently drop everything, throw your cup of tea over and run over to the other side of the ward opposite, and you are the first doctor to arrive. Oh, sorry, it's just frozen. So when you get there, you see a man in his 40s. He's sitting up in bed, and it's absolute chaos. There's nurses running around, there's leads flying everywhere, and you see that all over him there is a mix of kind of blood and brown vomitus all over the sheets. As you get there, he vomits another kind of 300 ml of coffee ground vomit, and he looks pretty unwell, but he is responsive to you when you're talking to him. You know that the medical team is en route, the peri-arrest has gone off, but in classic hospital format, they are the other end of the hospital in A&E, and it's a bit of a walk. So currently you are the only doctor in front of this patient. What are you going to do? So I'll start off with this one. I think I'll go through some answers and then we'll build up to some interaction. So obviously if you see this patient and the alert hadn't go off, the first thing you're going to do is call for help. The golden rule that I have when I assess patients is, am I happy leaving this patient on their own? Am I happy to go and make a phone call and leave the patient unattended? Am I happy to go and run a gas and leave that patient on their own? If the answer is no, then I need to get more help. The easiest way to get more help is to smack the alarm on the wall and start shouting, and that will bring people in your immediate vicinity over to you. Now, if you are on a day shift, that may mean your registrars, other junior doctors, senior nurses will come and help. But out of hours, it may be that there aren't other doctors around, but you'll get a few more nurses, some HCAs who come to support you. But regardless, you're getting more people in the vicinity. At that point, you can then say, right, I need someone to put out a peri-arrest or a cardiac arrest. I need someone to get some monitoring, and you've just got more hands on board so you can start to manage the situation safely. In this situation, there's lots of people running around waiting for your directions. So with any sick patient, or any patient really, you're going to start to do your A to E approach. So let's start going through an A to E approach on this patient. So the first thing is you need to think about the positioning of your patient. This is a patient who's actively vomiting, who is still cerebrating because they're talking to you. So I would initially at least sit this patient up at 45 degrees or a little bit more upright, just to try and stop them a risk of aspirating. Obviously, if this patient is unresponsive, you can't feel a pulse, then that's not the best position for them to be in. But in this scenario, he's responding to you, so I'd sit him up a little bit and make sure that if he's going to vomit, we can kind of protect his airway a little bit more. In terms of A, he's patent, he's talking to you in full sentences. And from a breathing perspective, you've got the SATS probe on. His SATs are about 96% on room air. His respiratory rate is about 26. There's no cyanosis. And when you have a quick listen, there's lots of secretions and transmitted sounds, but no kind of focal consolidation at the base or crepitations at the bases. And there's good global air entry. In this respect, generally, when I have an unwell patient, I think it's safe to put on some oxygen. Just bear in mind in patients who are vomiting, again, you want to think about the benefits of having a mask over them versus having nasal cannula, just again, because if they vomit into the mask, they're likely to have a high risk of aspirating. So this patient's got a slightly increased resp rate, which may be from a multitude of things. He may have aspirated, he may be incredibly stressed from vomiting lots of blood, he may be in pain, he's got fluid losses, he may be dehydrated. So there's lots of things driving the respiratory rate. I'd argue a little bit of oxygen wouldn't be inappropriate. But I think from this alone, your A and B are pretty secure at this stage. So then we get on to C. So looking at this patient, he looks pale, he looks awful. You do a quick cap refill and peripherally it's about 5 seconds and he's very cold to touch. Centrally it's about 3 seconds. You can see blood in and around his mouth. JBP looks okay, his heart sounds are clear, but he's tachycardic and profoundly hypotensive. So what are you going to do next? Well, in a patient who's whose cardiovascular system is decompensated, the first thing you need to do is try and get some access. Now, I think in all the textbooks and all the guidelines, it says get 2 large IV access or large IV access in both antecubital fossa, which is all very well and good. But I don't know how many of you have seen a big grey cannula, but they are pretty big. And advancing a cannula of that size and diameter can be tricky in young, fit, well patients, let alone when you have someone who is clinically in shock and peripherally shut down. So yes, if you can bash in 2 large bore IV cannulas, then good on you. I would try and aim for the biggest cannula as possible, so at least a pink. Try and get 2 in. The more kind of access you can get, the better. But you certainly need to get some access as per your ability and what's available. Once you get your access, you need to think about what am I going to take from this cannula. So the main things in this patient is firstly taking some blood samples. So getting a full blood count to assess for the hemoglobin. I'd get a baseline renals you can compare to any test he's had before, see what the urea is, which is important in your upper GI bleed. If there's any signs of AKIs, is there pre-renal AKI from chronic kind of bleeding that's not been picked up and they're hypovolemic. Getting some clotting, because that's going to be important for your management of your upper GI bleed. What is their INR? What is their APTT? And then one of the most important things you can do is get your 2 Rupin saves. And we'll talk about the importance of that later. Remember, these are the pink, I think the most trusted, the pink vials. And ideally, you should have 2 people getting these 2 samples. I need to hand fill out all of the information on these blood tests. Another thing you can do whilst you're there is get a VBG. It's quick and it gives you a lot of immediate information whilst you're still waiting for these blood tests to come back. So you get the VBG, someone's run off, you've managed to get 2 pink cannulas in, you've taken some blood and someone else is running those off, and the VBG comes back and this is the result. So you haven't got a computer available to have a look at previous blood results, but looking at this, his hemoglobin is profoundly low, 64. He's got a bit of renal dysfunction from his base excess and bicarbonate, and also his lactate is 4.6. And with the patient in front of you, you've got a patient who has actively vomited blood, who is in cardiovascular shock or hypovolemic shock, and with a low hemoglobin, high lactate, you suspect an upper GI bleed. So let's take a little break and talk about what can drive the upper GI bleeds. Oh, wrong way. So lots of different differentials for what might be driving your upper GI bleed. Now, in this situation where you have an acutely unwell, decompensated patient, your etiology is maybe on the back burner. The main thing is to resuscitate and stabilise. But in patients who perhaps come by GP or present to A&E, you might want to think about a little bit about what's driving the upper GI bleed if it's suspected. So the most common causes is your peptic ulcer disease, which can make up to 50% of presentations. This is actually followed by unknown cases, so about a fifth of cases we don't find a cause for the bleeding, despite extensive investigation. And variceal bleeding makes up a significant proportion of the etiologies as well. Other things to think about, so inflammation of the esophagus and the stomach, maybe from medications, from vomiting, from gastroenteritis, Mallory Weiss tears from repetitive vomiting. They may get fresh bleeding within the sputum, but normally low quantities and low volumes. Boar halves is rare as rupture of your esophagus. Again, they're going to be quite sick. You may have AVMs, malignancies, and you'd be unfortunate to have a fissure between your GI system and your aorta. Coagulopathies are put there as well. Just to bear in mind, a coagulopathy doesn't cause your GI bleed. It puts you at a higher risk of bleeding if there is a point that is bleeding. So coagulopathy is not a cause of the GI bleed, but it will certainly exacerbate it. And if there's small ulcers or there's oozing from a gastritis, if you have a coagulopathy, that's going to be a much more dramatic effect than the people with a normal coagulation screen. So just in terms of pathophysiology, we're not going to go into this too much because this is the bit that I find a bit more dry, but we'll go into the two biggest causes, so your peptic ulcer disease and your variceal bleeding. So when we talk about peptic ulcer disease, this is referring to both gastric and duodenal ulcers. There's lots of causes, but the most common is H. pylori, the bacteria, drugs, particularly steroids and NSAIDs, and smoking, alcohol, stress can all contribute. Briefly, peptic ulcer is a defect in the mucosal layer of your GI system. Usually there's a good balance between gastric acid production and protection of the mucosal lining, but causes such as H. pylori, drugs, alcohol can disrupt this balance and put your mucosa at a higher risk of being impeached and damage occurring. So a bit of a busy slide this, but briefly, if you think about your H. pylori and your NSAIDs as a cause. So H. pylori is a gram-negative bacillus. It's actually in most duodenal ulcers, people will be positive for H. pylori, and in a large percentage of the gastric ulcers, they'll be positive too. It basically causes an inflammatory response, so it drives lots of neutrophils, macrophages, lymphocytes to the mucosal layer, which causes the epithelial layer to start to break down and you start to get injury. Symptoms can be very mild, so initially starting with indigestion, epigastric pain, a bit of bloating, all the way through to having potentially ulcerations, which present with coffee ground vomiting, melena, and potentially symptoms of anemia. Your investigations, so from a non-surgical or interventional point of view, it'd be your urea breath test or your stool antigen tests, which again can be carried out in GP land. I think stool antigen test was what we used to use when I was doing my GP placement. Remember, they have to be off the PPI if they're going to have the stool antigen test done, otherwise you'll get false negatives. Equally, you can do biopsies within the OGD setting if there's a suspicion, and that can test for H. pylori as well. And treatment's really easy. It's a course of PPI and 2 antibiotics, and generally that has good effect in eradicating the bacteria. Then your other most common cause is your NSAIDs, so your ibuprofen, diclofenac, and NSAIDs work by inhibiting your COX pathway. So now we have our new selective COX-2 inhibitors like paracoxib, which try and limit the side effects of GI bleeding and kidney damage. But in your ibuprofen diclofenac, it blocks both your COX-1 and your COX-2 pathways. And essentially the COX-1 pathway is where you get most of the side effects. And one of those is that you get a dampening down of prostaglandins, which are protective to your gastric mucosa. So dampening down the prostaglandins put them at higher risk of damage and mucosal injury from etc. And then if you move to varices, so varices are linked to portal hypertension, which can can happen secondary to chronic liver disease, such as the cirrhosis, portal vein thrombosis. And you basically get a backflow, so you get a buildup of resistance within the portal venous system. The body tries to recruit excess vessels from the splanchnic system to try and increase the blood flow because of this backlog. And that's done by the release of nitrous oxide and other growth factors. And because of this backlog, you get this dilatation in your gastric and esophageal systems within the venous systems. And this is where the varices come from. And if you look in the top right, you can see an OGD picture where you've got these big swollen veins. And if you think of the thickness of the vein wall, they're very thin. And that puts in the high pressures within the portal system and within the varices with the thin venous wall at high risk of breaking and rupturing. And they can have quite dramatic bleeding from that. I'm very quickly just going to turn my light on because I realise I'm sitting in the dark. 1 second. Sorry about that. So they're the two main pathologies behind your upper GI bleed, which are important to think about in your management. So let's go back to our patient. So your patient is again, remember, is looking unwell. You've managed to get some IV access. Bloods are pending. So what's your next step? So maybe if we open this up to the Facebook Live, what would you like to do next? You've got 2 cannulas in, bloods are pending, you sent off your cross matches. But you haven't put any interventions in place at the moment. You've still got your BVG up there reminding you of the lactate and the hemoglobin. If I give you a couple of minutes, let's see if anyone can put some ideas of what they'd like to do next in this situation. And then hopefully one of my colleagues will tell me if anyone's put anything and we can discuss that. Are we getting any takers from my eyes and ears on Facebook? I think we're just waiting to hear. But it's weird this, I feel like I'm just talking to myself. Please respond.
So the first thing we've got is A2E. Yeah,
lovely. So we're doing our A2E assessment. So remember, we've looked at our airway and our breathing, and this is our circulation section. So yeah, correct. So within our A2E, we've looked at our pulse. So they're tachycardic and hypotensive. They're peripherally shut down. So remember, you can't move on to D until you've corrected C. So what things can we put in place to correct C? But thank you for the response. Thank you for engaging with me.
Someone said fluid resuscitation.
Yeah, excellent. So we need to start putting in some interventions, don't we? So I think fluids are certainly appropriate. We can go through fluid resuscitation and what things we would pick. So when we're thinking about fluids, we need to think about what fluids we would use, what volumes we would use, and how quickly we would give them.
So someone said 500 ml bolus over 15 minutes.
Yeah, perfect. I think that's a good. So if we think about our resuscitation, we're doing small boluses of fluid. So rather than 1 litre over long periods of time, we're going to give boluses of fluid. So I think 500 ml is appropriate in a 50-year-old with large volume losses. And over 15 minutes, yes, I would, in this patient, hook them up and squeeze it through as quickly as I could. I would even possibly go for, given how much blood I've seen and how hypotensive tachycardic, I might even go more than 500. But I think 500 is perfectly appropriate and a good response. Any other thoughts?
We're also getting some comments about the types of fluids. So sodium chloride, crystalloids, colloids, blood.
Yeah, good, excellent. So when we're thinking about our fluids, I won't go into too much detail because I think there's a presentation previously going into more detail about fluids. But you have your crystalloids and your colloids. Your colloids is mainly your human albumin, your gelafusin, which you don't use anymore, and blood products. And then your crystalloids are your Hartmann's and your sodium chloride. So I think for resuscitation purposes, normally we would use crystalloids, so your I think sodium chloride, Hartmann's is appropriate, or plasma-lyte, providing that your potassium is okay. But I think whoever said blood, I think that's an excellent shout, given that we have ongoing fluid losses that we know is blood, and blood for blood is an appropriate resuscitation technique. Lovely. Is there any other additions to that before I move on?
The only other thing that's been mentioned is broad spectrum antibiotics.
Yeah, so I think broad spectrum antibiotics is an interesting one. So presumably, I think we're thinking along, could this be a sepsis picture? Would be my inkling, or potentially if we're going down the variceal route. So I think, given the fact we have blood everywhere, my top differential for the patient being in shock would be hypovolemia secondary to hemorrhage. So we've got blood losses. Differentials for hypovolemic states include sepsis, so tachycardic hypotensive. Certainly with a high lactate, you're certainly thinking of sepsis as a differential. In this patient, he doesn't have a temperature. We have a low hemoglobin with witnessed blood loss, so it's lower down my differentials, but there's no reason why that we mainly think about antibiotics at a later stage. So I think definitely park that in the back of your mind. I think that's a good suggestion. Anything else? Or shall I?
That's all we've got at the moment.
Yeah, perfect. So thank you for your responses. I think they're all really good. So the main thing I think most of you are saying is that we need to resuscitate. So we need to resuscitate and try and stabilize this patient. So I think if I was seeing this patient, I would do fluids and blood products. So fluids being your crystalloids and blood products being your colloid option. So briefly with resuscitation, I think we went through this. When you're resuscitating, you're giving this to unwell patients. So are they hypertensive tachycardic? Are they septic? Are they bleeding? Are they in a hypovolemic state? So thinking about your fluid state of the examination, is this patient hypovolemic, euvolemic, hypervolemic? If they're going towards the hypovolemic end, you need to start to resuscitate them, particularly if you have someone who is decompensating. So again, when you're reviewing patients, is this patient well or unwell? Are they compensating or decompensating? And that's going to give you an idea about, do I need to go down the resuscitation, doing a very good A to E and making sure everything's stabilized, or can I relax and take, this is more of a maintenance, or, they're less unwell, but I need to maybe put some measures in place to stop them decompensating. In terms of so as we said, it's crystalloids, so your 0.9% sodium chloride or Hartmann's plasma-lyte as per your trust. Just remember to think about potassium in your Hartmann's plasma-lyte. But to be honest, in these patients, you've got a gas which will give you a baseline potassium, and providing it's not through the roof, I think whatever is on hand in an emergency is appropriate. And then normally in terms of your volumes, you're doing 250 to 500 ml boluses over 15 to 20 minutes, and you're reassessing after each bolus has gone through. In your smaller, frail populations, 250 would be more appropriate, particularly if there's a background of renal disease, heart failure, which may put them at a slightly more risk of third spacing if you give them too much fluid too quickly. But in young patients, 500 ml stat is appropriate. And the key thing with your A to E assessment and your resuscitation is that every time you put an intervention in, you need to reassess. You can't move on to the next thing until you've reassessed and happy there's been an improvement in your management. And then we go on to blood products. So in these patients, so if you're thinking about an upper GI bleed, you're considering blood products if there's ongoing bleeding, so hematemesis, melena, and or if there's sign of cardiovascular shock. So hypertension, tachycardia, a change in urine output, they might have a change in their consciousness level, and with the ongoing bleeding suggesting that if they're not in shock, they're heading towards that. Generally, we start with packed red blood cells. That's your mainstay of replacing blood for blood. But a bit later, we'll go into the other options in terms of FFP and cryo and reversing coagulopathies. And ideally, with the best way that we can give blood products is for cross-match blood, so for ABO compatibility. Now, if you have patients who already have grouping saves in the lab and you're sending your most recent sample, those patients can get blood products within 10-15 minutes. In patients who don't have any cross matches or grouping saves in lab, it can take up to an hour to get your ABO compatible blood. And that's what you need to bear in mind, that there's logistics to your A to E. And I think when you're at medical school, you get very used to talking through your A to E, but the logistics of it don't become clear until you're standing in that situation and realizing actually it's going to take an hour for my blood test to come back. the VBG machine is down the corridor. I need to lose somebody to go and run that gas for me. And it's going to take an hour for my blood products to get to me. What can I do in the meantime? Because in this patient who is actively bleeding, hypotensive, tachycardic, and in cardiogenic shock, you don't have an hour to wait for blood products before you do adequate resuscitation. So in which case we can think about, okay, we're waiting for our ABO cross matches, or our ABO blood to be cross matched in the blood. In the meantime, we can use the universal blood product, so O negative. So my next question to you is, you're standing there, you've got lots of nurses around you, you've spoken to blood bank and they're cross matching bloods, but it's going to take an hour. Where are you going to find your O negative blood? Where in the hospital do we keep it? So again, I'll give you a couple of minutes to have a think about where patients are most likely to be bleeding and where we'd need O negative blood on hand, and think about where you could physically send someone to pick up O negative blood from.
So someone said from pathology fridge, medication room in a fridge, theatres.
So the first one was at histology.
Pathology.
Pathology, yeah. So there would be blood up in blood bank. So wherever your blood transfusion lab is, they would probably have some in the fridge. Again, I have no idea in any of the hospitals where my blood transfusion lab is, which is probably really bad. I don't think I've ever had to go there, but there may be nurses and porters and that who know where to go. Medication fridges, no, we don't have. O negative blood is not on every ward, which is why it's important you know where it is. Theatres, absolutely. So if you run down to theatres, there will be an emergency fridge with O negative blood that you can take that from. So you've got blood transfusion lab, main theatres or surgical theatres. Anywhere else?
We've had one more comment that blood bank, but you can activate major hemorrhage protocol for porters to go and get the blood.
Yeah, good. So absolutely, we'll go into major hemorrhage protocol shortly. So if you have someone who, particularly in this situation, you should be putting out all sorts of calls. Remember, in the context of this, you're still expecting your med reg to turn up. A peri-arrest has gone out. So I would not expect anyone to stand there and start going through their A to E without calling for putting some sort of arrest or major hemorrhage call out with this scenario. But yeah, so you can certainly get major hemorrhage and you can get your porters to turn up. Again, your porters can go to blood bank, pick up the blood, come back again, but that's still going to take time. And it may be, I don't know how, if the porter's the other side of the hospital, you put the call out, they still know to get to you. So certainly a good option. So porters come with your major hemorrhage call. In terms of, let's go through the other options. So your places where people are going to bleed and people need to grab for O negative blood is your theatres, so surgical theatres, your maternity department, and your resus room, so in your A&E department. So bearing in mind, wherever you are in the hospital, if you know that actually just down the corridor is maternity, it may be quicker for a junior nurse to run down to maternity, get 2 units of negative blood, O-neg blood, and run back, and you can start putting those up. Remember, whoever is being sent, firstly, don't send the senior sister who knows everybody and how everything works. Send someone who is relatively junior but knows where they're going. Equally, if you're going to take blood from somewhere, you must tell somebody so they can restock the fridge. So there is a protocol of when you get there to say, there's a major hemorrhage, I'm taking O negative blood, and you need to sign it out. But as a backup option for you, and again, this is not the absolute you have to do it, but if you have someone who is unwell in front of you, you're struggling to get ABO compatible blood, it's good to know where your O negative blood resources are so that you can quickly run and get them. And then quickly, we won't go into too much detail on this, but the other part of blood products is thinking about, do I need to give alternative blood products? Do I need to give something to reverse coagulopathies? So you've sent your blue bottle with your INR, your APTT. And again, thinking about the drug chart, what this patient may be on, which may influence, do I need to reverse anything? So these are some, so again, platelets may need to be transfused. We have quite a high, we tolerate quite a low level of platelets before we transfuse. Vitamin K for warfarin, and then these are all your fancy options for your DOACs and whatnot. But again, you would not be expected to start any of this management without senior discussion, or at least talking to haematology about it. You certainly wouldn't be expected, and I don't think you really should be doing interventions like this at anyone's stage until you have, you get into med reg level, and these decisions can be balanced. So please don't start prescribing Adonexanet alpha because I told you to. But it's good to be aware of, actually, are there reversal agents for these medications? Do I need to thinking about having a look at the drug chart? Is there anything else I can reverse, or I need to be thinking about that could be exacerbating my situation? So major hemorrhage is what we were talking about earlier, someone brought up. So I'm making you do quite a lot of work in this teaching, but thinking about your major hemorrhage call. So when would you put it out? What constitutes a major hemorrhage? What does it actually mean? So when you put the call out, who's going to get the call, and what happens, and who will arrive? So let's see if we can get any answers for this one. We won't do too long, but at least you don't have to listen to me talking for too long. So when do you put a major hemorrhage call out? What would be your criteria? What does it actually mean? And who turns up when you put the call out? Because remember, whenever you're putting out a peri-arrest, a cardiac arrest, a major hemorrhage call, you need to understand why you're putting it out and who's going to turn up to help you. So in some trusts that I've worked at, if you put a peri-arrest call out, the anaesthetist doesn't turn up. They only turn up to cardiac arrest calls. In other trusts, they turn up to all of them. So you just need to be a bit aware of, why am I putting this call out? Who do I actually want to turn up to help me? And is this the best call for that to be done? So have you got any thoughts on major hemorrhage call coming through?
Nothing as of yet.
No. Give it a couple more seconds, otherwise I'll tell you the answers.
So someone suggested when the patient has bled more than 3 liters of blood.
Yeah, I mean, yeah, I would say 3 liters of blood, absolutely. Quite a lot of blood. I mean, 3 liters at 100%. But I think it's a large volume of bleeding is certainly appropriate. We'll talk through the quantification of major hemorrhage in a second. I think it's interesting with major hemorrhage, when we think about volumes, it's incredibly difficult to judge volumes of a liquid when it's over bed sheets in different formats. If it's in vomit, in melena, it's incredibly difficult to quantify. So I think clinically is sometimes a little bit easier. Have we got any other thoughts coming through, or?
Yeah, we've got a couple more. A couple of people talked about MET teams, or medical emergency teams.
Yeah.
And also someone suggested bleeding in excess of about 150 mils per minute.
Yeah, absolutely. Yeah, again, yeah, I think that is part of the criteria for major hemorrhage. Again, measuring 150 mil per minute of blood loss is incredibly difficult in person. So I think really these are all good ideas, and it's talking about volumes is interesting because I think it emphasizes how difficult it is to quantify. But I think you're correct. 150 mil per minute is part of the criteria. Very good. And MET teams, absolutely, your medical emergency teams. So your med reg, your SHOs on call, the F1s on call will certainly arrive. And the resuscitation team in some trusts, so your CCOT nurses, your critical care outreach team will turn up. Good. Is there anything else, or shall I move on and give some answers?
Just the last one that's come through, just saying have a low threshold.
Yeah, I agree. So let's have a look on the slide and we'll talk through. So I completely agree. So the actual criteria we said is more than 150 mil per minute. So well done, that person who came up with that. Or they're saying 30% of circulating volume in 3 hours, so about 1.5 litres. or profuse bleeding. To be honest, I think profuse bleeding, whether or not it's going at 150 ml per minute, if someone is bleeding, then absolutely. In terms of 30% circulating volume, if you've lost 30% of your circulating volume, I think you're in about class 3 shock. So clinically, they're going to be hypotensive, tachycardic, not passing much urine, confused, combative, tachypneic. So I think in terms of your judgment, firstly, clinically, does this patient look like they are losing a lot of blood and decompensating from it? And secondly, I would argue, if you are there and you think, do you know what, this person is losing a lot of blood, I can't quantify it because it's absolute carnage, there's blood everywhere, they look unwell, I would have a low threshold to put in a major hemorrhage call out. Now, in terms of actually putting the major hemorrhage call out, what it means is that it's alerting the blood transfusion lab that at some point blood products may be required. And it also, in some trusts, alerts the consultant or registrar hematologist on call. And the point of that is to emphasize that this does not mean immediate delivery of blood products. You don't put the call out and someone runs towards you with blood. It's alerting the blood to be ready for the call that will say, we need these blood products, we're activating the major hemorrhage protocol. And in that respect, it's important to know who arrives. So the MET team, absolutely, well done to whoever said that. So your on-call medical team, your medical registrar, your SHOs, your F1s on call will turn up to help you. So you've got even more hands on board. You also get intensive care anaesthetists to turn up, because if they're critically unwell, they're going to need airway support, potentially inotropes, etc. I think someone said earlier, porter, a really important part of the major hemorrhage protocol turn up, because they will physically be running backwards and forwards from you to the lab to collect the blood and bring it to you. And you also get a surgeon who turns up, so certainly out of hours, the surgical registrar will arrive, because again, we need to think about definitive management. If the bleeding doesn't stop on its own, there's ongoing losses, we need to physically stop the bleeding. Out of hours, it will depend on your trust and if it's a big tertiary centre or a small DGH. Out of hours in my DGH, we don't have a gastro-reg or consultant on call, so they won't be turning up to the major hemorrhage, but in hours, they may get the alert through. So the main people is your medical team, your ITU anaesthetic team, surgical team, and the porters. But importantly, you won't get the blood immediately. You have to have an allocated person who will ring the blood bank and ask for the blood to be cross-matched and delivered. Good. Well, this hasn't come across very well, but in terms of we were talking about hemorrhagic shock, how to clinically quantify it. So I think the definition earlier was it was 1.5 litres over 3 hours of blood loss, or about 150 ml per minute. So we're talking about stage 3, stage 4 hemorrhagic shock. I think originally this was in relation to trauma, but I think it qualifies across all hemorrhagic shock. So if you have patients with this huge volume of blood loss, where they're going to be tachycardic, low blood pressure, pulse pressure's low, they're tachypneic, they've got low urine output, and they're getting combative and confused. So even if you can't measure your the mil per minute of blood loss in your patient, you can still clinically think, actually, how unwell is this patient? But to be honest, I think if I was with a patient who'd lost a litre of blood in front of me, had a normal blood pressure, was a bit tachypneic, I think with any blood loss, I'd have a low threshold to put the major hemorrhage out. Because remember, I don't know if I can go back. Remember, the worst case scenario is that if you put a major hemorrhage out and all these people turn up, the worst case scenario is that it gets stepped down and seniors are there and they take over care. You're not wasting any blood products, because until you ring the lab to ask them to start cross-matching and giving the patient details, no blood is being produced. It's just putting them on standby. So as we said before, whoever suggested about using your own judgment, I would have a low threshold. And if you're out of your depth, you need help, and someone is actively bleeding, major hemorrhage protocol is appropriate. This was taken, actually, I think from Charing Cross and Hammersmith. This is the transfusion protocol, which I thought was quite a nice summary. So when we are speaking to the lab, when you're at your major hemorrhage call, one person is allocated to be the person who is the liaison between the emergency and the blood bank. It's one person only. They are the person who sits by the phone, and their job is to ring the blood bank, give the patient details, and request the different packs of blood. No one else should be making those phone calls, because then it just gets confusing and there's no, there may be delays in the delivery of the blood. Different trusts have different protocols, but generally we talk about pack A and pack B. Your pack A is your packed blood cells and FFP. And so when we say, yes, this is a major hemorrhage, we need to start transfusing, the person nominated will ring the blood bank with patient details and say, please, can you start producing pack A? And then the porter goes to collect them. At which point the blood bank will continue to produce 4 packs of red blood cells, 4 packs of FFP, that's cross-matched, and will continue to produce that until the person who is on the phone tells them that it's no longer required. Once that's going through, so you put up red blood cells, you put up some FFP, and you're squeezing those through. The other thing you can start considering is pack B, which is your platelets and your cryo. And again, if you've got large volume bleeds, you need to start replacing clotting factors as well, and platelets. You can't just keep replacing with packed red cells. So pack B can also be initiated. And again, it is the responsibility of the person who is ringing and liaising with the lab to ring them and get that blood organised. And remember that that person needs to tell the lab if the patient has sadly passed away, or if the patient is going to theatre, or they have now been stabilised. They need to ring them and say, we no longer need you to keep producing pack A or pack B. And just over on the right-hand side, there's just the reminder about how long it takes for blood products to be cross-matched. So your emergency at no neg you can get immediately if you run there and pick it up. Your group-specific blood is variable depending on cross-matches in the lab. And your fresh frozen plasma and your cryo is actually frozen, so it takes 30 minutes to thaw. So again, you need to factor that into your decision-making. And in some trusts, certainly at my trust, sometimes it has to be delivered by a man on a motorbike from a different trust. So that's something else to consider, that if it's not on site, it may take even longer. So lots of logistics behind your major hemorrhage. What time are we on? I've been talking for a long time. So let's go back to our scenario. So you've done an excellent job. Your med reg is still miles away, really taking their time, but you have absolutely smashed it. You've got 2 large cannulas in, you've sent loads of blood, there's IV fluids running, you've put a major hemorrhage out, and there's a junior nurse en route to get some O negative blood. Even though this is a scenario that would never happen, because you would never be left alone to deal with this on your own, and this is not to frighten anybody, this is all hypothetical. You will never be left to manage this on your own at any stage. But you're doing a great job so far. Let's think about if there's anything else we could be doing. So I'll whip through this because I think we've been talking for a long time. But again, we put an intervention in, so you've given some fluids, you're waiting for some blood products, you're going to go back to A. So is my patient still talking to me? Have we lost an airway whilst I'm focusing on getting IV access? Do I need to reprioritise? Because remember, your A to E is what's going to cause mortality, cause the patient to pass away first. Their airway, their breathing, the circulation. So this patient has a huge circulation compromise, but we still need to make sure A and B are stable before we continue with C. So go back to A, he's still talking to you. He's a bit drowsy, but he's responding. There's no adjuvants needed. He's still on that little bit of oxygen. His breathing is stable. He's a little bit tachypneic, but no changes. You go back to C, your fluids have gone through. There's a bit of an increase in the blood pressure. You're going to give some more fluid. You're still waiting for that blood to come. Other things you can do, so you might, if appropriate, if the patient is stable enough, you might want to do a PR, see if there's any melena, or have a look, is there any melena coming out? Because if there's melena, you don't need to do the PR. Is there fresh blood that may suggest it's not an upper GI bleed, it's a bit lower down? An ECG is appropriate, so if they're tachycardic, you want to make sure it's sinus rhythm, there's no arrhythmias complicating things. Are they in AF? And actually that might make you think, oh, is there an anticoagulation background to this patient? And equally, if you have a patient who has a history of ischemic heart disease, it's good to get an ECG to look at the rhythm, because these patients may be at a risk, if they're very hypovolemic, of having secondary MIs. So an ECG, a tachycardic patient, is appropriate. If able, I would try and get a urinary catheter because this is a resuscitation attempt. We've got ongoing fluid losses. We're trying to replace them. So we need to know from a kidney point of view how much urine output we're getting, because again, that will be suggestive of successful or not resuscitation. Again, I wouldn't prioritize that over access, blood, fluids, but if there is someone handy who can put a catheter in, then certainly something to consider. You may want to give some drugs, so IV PPI, either as a bolus or an infusion, is recommended by some trusts. In more stable patients, there's an argument that giving the PPI may make it difficult to identify lesions on OGD at a later stage. However, some trusts say that in patients who are majorly having huge hemorrhages, then giving IV PPI infusions as a resuscitation approach is appropriate. So it would be dependent on your trust. And then remember to have a look at your drug chart. Are they on any antihypertensives, beta blockers that may be giving me a false reading from the observations I'm getting? Are they on any blood thinners? Is there anything on there that, are they on NSAID steroids that might be causing this GI bleed? But as I said, you won't be doing all this on your own. There's no way we would, after a peri-arrest and a major hemorrhage, that you would be there doing all of this on your own. This is all just hypothetical, to reassure you. So the nurse now comes over and says, oh, I've got a bit more background on this patient who's actually admitted this morning with this weird seizure thing that he had at home. And the doctors have started on this drug called chlordiazepoxide, and there's some Pabrinex going through. It looks like he's got a history of alcohol excess, liver cirrhosis, and it looks like on OGD there's actually been some visualized varices. But he's not on any medication really. He's got poor compliance and there's no known drug allergies. So you think, oh, that's unusual. Let's have a closer look at this man. And lo and behold, you realise that he is visibly jaundiced. He's got a big distended abdomen. There's shifting dullness when you examine, and it's tense. And he's got a low BMI. Otherwise, again, from a GCS point of view, he's a little bit confused, but otherwise, GCS is about 14, and he's afebrile. And here you're finding, so big tense abdomen, jaundice of the sclera. He's got these caput medusae, dilated abdominal wall veins, and spider nevi on his abdomen. So you think, I wonder if there's something else going on here. So if we think back to our causes of upper GI bleed, we've said main things are peptic ulcer disease or potentially variceal bleeds. And in this patient, given that he looks like he might be in decompensated liver failure with previous varices on OGD, I think variceal bleeding would be an appropriate differential. So in these patients, terlipressin is an option for management, which essentially causes vasoconstriction to stop bleeding. Again, it would not be appropriate to prescribe this without senior support. Remember, this is a potent vasoconstrictor, so in some patients with, again, ischemic heart disease, it may not be appropriate to give them. So it's a risk-benefit balance, and this would be under either senior or specialist supervision that it'd be given. But it's good to have that in the back of your mind, that is variceal bleeding a differential? Is it something I could suggest as an intervention we could give? And in these patients, antibiotics, which I think someone said earlier, would certainly be appropriate. If you've got a variceal bleed, there's been a rupture of a mucosal membrane and venous membrane, then they're high risk of getting infections. So in my trust, tazocin is the first line, but it would be variable in your trust. So this is where thinking about your etiologies may slightly change your management. But again, this is much further down the line, and regardless of the etiology, your A to E approach and resuscitation management is still appropriate. We're nearly done, I promise. So in terms of definitive management, the main things is the priority is resuscitate and stabilize, but the next steps are going to be, where is the bleed and how can we stop it? So your seniors may suggest we need to go for an OGD if they're convinced this is an upper GI bleed. Flexi-sig, CT angios may be alternatives. So if OGD is negative, is there something lower down they can find? Remember with melena, I think up until the hepatic flexure, you can still get melena from GI bleeds from the mouth down. So it may be much lower down than the OGD can reach. And in patients who are not suitable for OGD, sometimes CT angiograms can be used. Your OGD can be diagnostic and therapeutic, and more dramatic methods of management can be put in place. If they can't ablate or put adrenaline into the ulcers, they can do what they call them, where they can ligate the varices on OGD as well. But if that's not appropriate or there's different causes, these more dramatic methods can be used, which I won't go into now, but it's good to be aware of because they may be used at tertiary centres. And then very quickly, I don't want to bore you too much with this, but some scores you might be familiar with and you may be asked for in upper GI bleed patients, particularly those who are coming to A&E, have ambulated in, who are relatively stable. Your Blatchford score you do before your endoscopy, and it essentially quantifies patients who would require treatment and intervention and therefore require admission. So if your patient's urea, hemoglobin, blood pressure is all okay, and they've got no other concerning features, they may be able to go home and have outpatient management. If they're scoring highly, then they may need to have inpatient review and inpatient intervention. And the endoscopy department may ask the Blatchford score to try and prioritise patients who need intervention that day. And then sometimes you may see the Rockall score used afterwards, so once they've had their intervention done. And this essentially is a score that helps try to identify patients who are at higher risk of bleeding or have a higher risk of mortality, even after the OGD, who might need to have further investigations or interventions done. So just scores to be aware of. You don't need to know these off by heart. If you're asked for them, you can go onto MedCalc and use them, but it's good to understand why they're used. So that is the end of me talking at you. Well done if you've made it this far. So remember, the main things you need to do is reassess, reassess, reassess. Whenever you put an intervention in place, you must go back and start again and make sure nothing else has changed. My main take-home messages with upper GI bleed and any other scenario is call for help early. You'll never be criticised for calling for help early, but you don't want to get yourself too far down the line where things are getting a bit out of hand and you're calling for help and you're out of your depth. So call for help early. Do your A to E assessment and make sure you have completed or treated A before you move on to B, treated B before you go on to C. The main things in your unwell patients is to firstly resuscitate and stabilise before you're going on to thinking about interventions. Be familiar with your TRUST major hemorrhage protocol and from that your peri-arrest and cardiac arrest protocol. Make sure you know who's going to turn up when you put the cardiac arrest, the peri-arrest out. And if in doubt, always ask whether you're F1s, F2s, SHOs, registrars, people are always happy to help you. And it's easier to ask. If you don't know the answer, don't sit there worrying about things. Ask someone for help so that you learn for next time. These are my resources. I haven't laid them out very well, but that's what I used for today's presentation. And if you have any questions, do let me know. And thank you for listening and participating.
So we've just got a couple of questions that have come through so far. One question is, any thoughts on tranexamic acid and its use in these settings?
Yeah, so I think tranexamic acid, again, in a major hemorrhage is appropriate. Again, with any medications that you give, you need to weigh up the risks and the benefits. So giving them tranexamic is going to put them into a more prothrombotic state. In a major hemorrhage, I think completely appropriate because you have an active bleed in front of you versus a hypothetical risk of clotting. In some patients, they may be higher risk for giving tranexamic acid. I think, again, as an F1, you would not be necessarily expected to give tranexamic. And I think by the time you're getting to that point, you should have given fluids and given blood products before that and getting access. And by the time most of that's done, you'll have help next to you already. But certainly something to think about. I think tranexamic is certainly appropriate in any big bleed, but with any drug, just weigh up the pros and the cons and think about any contraindications for that patient that may make you think, maybe not. But yes, in a big major hemorrhage, tranexamic would be appropriate.
There's another question about the role of, just generally querying the role of beta blockers in upper GI bleeds as well.
So the role of, so in terms of, I think there's two aspects to that. So being aware that a patient is on beta blockers is helpful in terms of, is that drug masking their symptoms? So for example, even in any sick patient, say if you'll get your call to see a patient who has a temperature, they might have a bit of a low blood pressure, but their heart rate is 80, 70, 80. And you think, oh, that's okay, they're not meeting the sepsis guidelines. If they're beta blocked, they're going to have their natural response to having a sepsis, infection, hemorrhage is going to be blunted by the bisoprolol or the whatever beta blocker they're on. So it's just important to bear in mind, has this patient taken a beta blocker, and am I getting a false reading for that heart rate? Because if the drug is stopping them having a natural response, if the tachycardia is a way to maintain that blood pressure, and if the beta blockers are stopping that response, then it's just something to bear in mind. In terms of beta blockers within the context of upper GI bleed, propranolol is used as a for varices in terms of like prophylaxis for bleeding. So there is a role in terms of the prevention, but in terms of acutely unwell patient, you wouldn't give any beta blockers to this patient who's bleeding, because the tachycardia is the main thing that's maintaining that blood pressure. Does that answer the question, or is there something I'm missing from that one?
Just while we wait to hear back from that person, there's just a couple more questions. One is about spontaneous bacterial peritonitis, which I think we'll cover in another webinar, but there's also one just regarding like when we would use FFP versus cryoprecipitate versus platelets in this sort of setting. Yeah,
so it's a difficult question. So again, it's not something I'm hugely confident on either. I was having a read for this presentation. So my understanding is that your FFP is clotting factors and your cryoprecipitate is primarily fibrinogen. So I think for patients, for example, patients who are warfarinized with high INRs, you might give some clotting factors as well to try and reverse the, was it 10, 9, 7, 2, which are inhibited in your clotting cascade for warfarin, whereas your cryoprecipitate is more fibrinogen. And I think within the cryo, it's a smaller volume and more concentrated. So both of them are derivatives of plasma, and both have roles within major hemorrhage or bleeding patients. It's dependent on what your clotting shows you. And to be honest, I certainly wouldn't be prescribing FFP or cryo without having advice from a haematologist, because it's one of those things that I'm certainly not confident on, if I'm honest. So my understanding is that cryo is fibrinogen predominantly, and that FFP is clotting factors. Both are plasma derivatives. And in major hemorrhages, you're losing not only hemoglobin-packed red cells, you're losing plasma, you're losing platelets. So in major hemorrhages, if you just replace the hemoglobin, you're still going to have coagulopathies if you don't replace the clotting factors. So the reason that we give not just packed red cells, we give platelets if the platelets are low, we give clotting factors, is that you need to replace the whole package as a whole, basically. But that's kind of the extent of what my understanding is, without doing some hematology revision. So I can certainly ask around, and if we get a better answer, which I'm sure we will, to that question, we can post it a bit later for you.
So that's all the questions that we've had come through. But of course, if anyone has any further questions, you can always get in touch with us via Facebook or via email, and we can always answer those questions as well.
Absolutely.
Great. So if you could, thanks firstly to everyone who attended today. That was a really useful session as well, Lizzie. Thanks so much for putting that together. If anyone does have any further questions, please do get in touch with us, and please do fill out that feedback form that we posted. That's also how you'll get a certificate for attendance, and it also really helps us in terms of knowing what we can do to make these sessions even better for you. And there's a QR code on the screen now in case anyone would rather use that. But yeah, other than that, we'll hang on for a minute or so more in case anyone has any further questions. But thanks so much for attending.